And the primary outcome that we try to focus on between beta blocker group and non-beta blocker group is that they try to find out the death from any cause or any myocardial infarction. And we see the primary endpoint here between two groups is not statistically significant from the hazard ratio. It was 0.96 and the p-value was 0.64. The secondary endpoint between the two groups, then beta blocker group did not appear to lead in lower cumulative incidence of the secondary endpoint. So, like death from any cause, death from cardiovascular disease, myocardial infarction, hospitalization, and the safety endpoint will appear to be similar between two groups. Uh, the primary endpoint we can see from the chart here that both line from beta blocker group and the non-beta blocker group was overlap each other regardless of time. And the death from any cause, like the same thing, both groups overlap each other over time, and the new myocardial infarction same. For the discussion, so we can see that the strength of this trial that yes, they have a power study at 80%. It's a long time study from 2017 to 2023, multinational, and comorbidity was well matched between two groups. The weakness is that it's an open label trial, so the prescriber already know which one to give to. Mostly in Sweden, 95.4% in Sweden. See, the primary endpoint was not statistically significant, with the p-value is 0.64 and alpha is 0.05. So, and then two groups have significant crossover between. So we have beta blocker group, 90.6% continue taking beta blocker, and 8 for 6 to 10 weeks, and 81.9% patient continue taking beta blocker after 11 to 13 weeks. In the non-beta blocker group, some patients start taking beta blocker, like 11.3 took beta blocker after 6 to 10, and 14.3 took beta blocker after 11 to 13 weeks. So for the clinical implication, the open label retrospective study showed that beta blocker did not reduce the cardiac event as a secondary prevention for patients with post-myocardial and preserved ejection fraction. Other observation study in South Korea conclude that beta blocker long-term usage should be guided by LVEF. So it showed the beta blocker showed the benefit for LVEF less than 40%, but reduce the mortality in to 30 to 35% per heart failure guideline. The mortality was not even significant and different when using beta blocker with LVEF more than 41 and 49 and 50%. So my opinion is that it would require more study to change the practice to using beta blocker for secondary prevention and update the guideline. In this context, no, I won't stop it. It'll be case by case. That's why we have a six-month follow-up. And the duration of beta blocker usage should be guided by the comorbidities such as kidney failure, heart failure, especially with the ejection fraction less than 40%. Yes, I agree to continue in those scenarios. And however, if patient want to stop and want the provider to stop it, then we can explain the pros and cons, educate them, and then if they understand the risk and benefit, then we can start taper off. But we have a 3 to 6 month follow up to see how it's function, how the patient activity go with the reduced dose beta blocker, and then how it's different when without beta blocker. So I will not stop right away. I will evaluate how the patient function slowly over time. So it'll be further discussion with more study in this. As far as this scenario, no, I won't change anything unless the patient demands it.